So continuing with our question 22 of previous year NEET PG questions, 2024 question. So which of the following is the most consistent with these symptoms? So the symptoms are: a 62 years old female presents with left-sided arm and leg weakness, right-sided complete facial paralysis, and difficulty with horizontal eye movement. So let's put these in technical terms. Left-sided arm and leg weakness is left hemiparesis or hemiplegia. There is a right-sided complete facial paralysis. The word complete is very important here because in facial paralysis we have two types: upper motor neuron type of facial paralysis and lower motor neuron type of facial paralysis. You would have known in the nerve supply of face there is bilateral innervation of upper motor neuron fibers. Okay, the particular sided upper motor neuron fibers supply both the upper halves of the face and the lower half of the face. So there is contralateral innervation. So in upper motor neuron palsy, we'll draw the other side also. So this side also innervates both the upper halves and single half, lower half. So when one-sided upper motor neuron fibers are affected, definitely the lower half of the face will be affected, but the upper half is spared because of the contralateral innervation from the other side. Okay, this is some fact which we must remember. So in upper motor neuron paralysis, there will be only lower half of the face will be palsied, whereas if it is a lower motor neuron type of palsy, the entire half of the face will be affected. So that is the word here. So they have given right-sided complete facial paralysis. So this is a lower motor neuron type of facial paralysis of the right side. So what do we have? We have left hemiparesis and an opposite-sided facial LMN paralysis. So that's a crossing of sides, right? Left and right. And difficulty with horizontal eye movements. Most of us will not be able to pick up this clue, and I think it's not relevant because the other two clues are enough. This is actually a case of crossed hemiplegia. So when do you say a person has crossed hemiplegia? When there is hemiparesis of one side plus actually it is hemiparesis of contralateral side and ipsilateral facial or cranial nerve palsy. I'll just explain it in brief. You know very well that there will be crossing of fibers, crossing of the corticospinal tract fibers at the level of the medulla. So assume that there is a lesion somewhere in the brain. Assume that it is in the pons. Okay, that is the corticospinal tract has not yet crossed. So there is a lesion in the right-sided level of pons. So what will happen to the corticospinal tract of the right side will be affected. That will cross to the left side in the medulla and it will innervate the left half of the body, left arm and left leg. So when there is a lesion of the right pons, there will be left hemiplegia or left hemiparesis because of the crossing occurs at the level of the medulla. At the same time, cranial nerves have an ipsilateral supply. So when the right pons is affected, pons has the lower motor neuron fibers of the facial nerve or the seventh nerve. So there will be LMN type of facial palsy of the right side. So you can see how there is a crossing. There is a left-sided hemiplegia because right-sided pons is affected and the right-sided corticospinal tract is affected. There is a left-sided cranial nerve palsy. In this case, it is a facial nerve palsy. So it will affect in the same side. So that is why the term ipsilateral and that is why the term contralateral. So an ipsilateral cranial nerve palsy and a contralateral hemiparesis, this combination together is called as crossed hemiplegia. This crossed hemiplegia will occur only when part of the brain stem is affected. Please remember. So what are the parts of the brain stem? As you know, there are midbrain, pons, and medulla. These are the parts of the brain stem. And you also know very well that two cranial nerves originate from the midbrain. They are the third nerve and the fourth nerve. Third nerve is the oculomotor nerve. Fourth nerve is the trochlear nerve. So these two help in eye movements. So the same situation occurs here. If there is a lesion in the midbrain in one side, for example right side, the right side third nerve and fourth nerve will be affected, but there will be a left-sided hemiplegia, right? What are the cranial nerves which arise from the pons? They are 5, 6, 7. Fifth nerve is the trigeminal nerve. Sixth nerve is the abducens nerve. Seventh nerve is our famous facial nerve. Okay. We can say the eighth nerve also. Eighth nerve is the vestibulocochlear nerve. But people say it originates from the pontomedullary junction. So anyway, it is taken as pons only. Now what are the cranial nerves which originate from the medulla? The lower four cranial nerves. 9, 10, 11 and 12. Ninth nerve is the glossopharyngeal nerve. 10th nerve is the vagus nerve. 11th nerve is the spinal accessory nerve. And 12th nerve is the hypoglossal nerve. So we discussed third nerve and fourth nerve has to do with the eye movements. Fifth nerve supplies the face. They control the muscles of mastication and as well as they carry sensations from the face. Sixth nerve is again for eye movements, abducens nerve. Seventh nerve or facial nerve helps with muscles of facial expression. Remember, trigeminal nerve is for muscles of mastication and facial nerve is for muscles of facial expression. Also, they carry sensations from the tongue, anterior 2/3 of tongue. Vestibulocochlear nerve is for hearing as well as balance. Glossopharyngeal nerve carries sensations from the posterior 1/3 of tongue as well as they help in palatal movement. Vagus nerve supplies the larynx and pharynx. Spinal accessory nerve supplies two muscles, trapezius and sternocleidomastoid. Hypoglossal nerve controls the motor movement of the tongue. So this is just a basic revision. Knowledge of this is important because in crossed hemiplegia we have some named syndromes. For example, there are many syndromes. We'll just tell few important things. There's something called Weber syndrome. Weber syndrome is very easy. Weber syndrome is a midbrain syndrome. I told you there will be hemiplegia, right? So there will be, if one-sided midbrain is involved, there will be contralateral hemiplegia. And what cranial nerve comes in the midbrain? It's the third nerve. So there will be problems with eye movements. So contralateral hemiplegia plus ipsilateral third nerve palsy. Right? If you read the cross section of midbrain, there are some important structures such as red nucleus, third nerve nucleus and fourth nerve nucleus. Based on that, we have few other syndromes, like something called as Claude syndrome. Like if red nucleus is involved, there will be the same thing. There will be contralateral, there will be ipsilateral third nerve palsy. That is the same. Plus, instead of the corticospinal tract, if red nucleus is involved, we will be having contralateral ataxia. Right? So, Weber syndrome is ipsilateral third nerve palsy and contralateral hemiplegia. Claude syndrome is ipsilateral third nerve palsy and contralateral ataxia. We have Benedict syndrome. Benedict syndrome is combination of Weber plus Claude. So there will be ipsilateral third nerve palsy as expected, plus there will be contralateral hemiplegia, plus contralateral ataxia. So ipsilateral third nerve palsy because third nerve nucleus is affected. Why contralateral hemiplegia? Because corticospinal tract is affected. Why contralateral ataxia? Because red nucleus is affected. So the midbrain syndromes are Weber syndrome, Claude syndrome, Benedict syndrome. We have few other syndromes. We are not discussing everything to avoid confusion. In Pons, think of Millard-Gubler syndrome. So Millard-Gubler syndrome is again ipsilateral seventh nerve palsy. Okay, ipsilateral seventh nerve palsy and contralateral hemiplegia. Ipsilateral seventh nerve palsy. So there will be element type of facial palsy in one side plus contralateral hemiplegia. Again, we have many other syndromes, like there is a syndrome called as Fovili syndrome. It is also Fontaine syndrome. Fovili syndrome is a same hemiplegia, contralateral hemiplegia with sixth nerve palsy. Okay. Actually, Millard-Gubler syndrome will involve both the sixth nerve palsy as well as the seventh nerve palsy. That's why in Millard-Gubler syndrome will be having a facial palsy as well as a gaze palsy plus contralateral hemiplegia. Whereas Fovili syndrome will have only sixth nerve palsy. That is, there will be contralateral hemiplegia plus ipsilateral abducens nerve palsy. So there will be gaze palsy. So that is Fovili syndrome. Coming to medullary syndromes, we have one famous syndrome, the lateral medullary syndrome. Lateral medullary syndrome is also called as Wallenberg syndrome. We have another syndrome called medial medullary syndrome, also called as Digerin syndrome. Remember, in cross section of brainstem, sensory is lateral, motor is medial. Sensory is lateral, motor is medial. So when thinking of lateral medullary syndrome, there will not be hemiplegia, but there will be contralateral hemianesthesia or contralateral hemisensory loss. Plus there will be ipsilateral features of, there will be contralateral hemianesthesia. Plus we have few other structures which are lateral, like the entire trigeminal tract is lateral. Okay, the hearing apparatus is lateral. So we'll be having cerebellar symptoms because the cerebellar fibers will be lateral. So there will be ataxia here. Okay. Ataxia and ipsilateral facial sensory loss. So just remember three things. There will be contralateral hemianesthesia plus ipsilateral ataxia and facial hemisensory loss. So why contralateral hemianesthesia? Because okay. Coming to medial medullary syndrome, what all is medial? Entire motor is medial. Tongue is medial because tongue, hypoglossal nerve is also a motor nerve. So there will be tongue palsy, which is ipsilateral, or hypoglossal nerve palsy, which is ipsilateral, and contralateral hemiplegia. So if you are getting confused, we'll just summarize it shortly. There is a term called as crossed hemiplegia, where there is a lesion of a particular side of the brainstem, whether it is a midbrain or pons or medulla. So in crossed hemiplegia, there will be ipsilateral cranial nerve palsy and a contralateral hemiplegia. For example, in Weber syndrome, there will be ipsilateral third nerve palsy and a contralateral hemiplegia. In Millard-Gubler syndrome, there will be ipsilateral sixth nerve and seventh nerve palsy and contralateral hemiplegia. Fovili syndrome, there will be ipsilateral sixth nerve palsy and contralateral hemiplegia. Lateral medullary syndrome, there is ipsilateral ataxia, facial hemisensory loss, and contralateral hemianesthesia. Right? So these are some of the syndromes. Now I think this question will make sense. Patient is having a left-sided arm and leg weakness, right-sided facial palsy. So there is right-sided seventh nerve palsy, and they are given difficulty in horizontal eye movement. Probably it is a sixth nerve palsy, and there is a left-sided, that is a contralateral hemiparesis. So this is clearly a crossed hemiplegia with sixth nerve and seventh nerve involvement. The answer is Millard-Gubler syndrome. Had they given only a problem with horizontal eye movement, the answer would have been Foveli syndrome. Okay, seventh nerve plus sixth nerve is Millard-Gubler, only sixth nerve is Foveli syndrome. Benedict syndrome is a crossed hemiplegia syndrome of the midbrain. As discussed, involvement of red nucleus and involvement of corticospinal tract. So here there will be contralateral hemiplegia, contralateral ataxia, and ipsilateral third nerve palsy or oculomotor nerve palsy. Wallenberg syndrome is lateral medullary syndrome, where there will not be hemiplegia, there will be contralateral hemianesthesia and ipsilateral facial hemisensory loss and ataxia. Okay. So coming to our next question, question number 23 in previous NEET PG. It's a 2024 question. So this seems a very big question with an image. So reading from the last line, which of the following will be the appropriate next step to order? So we have to find out the diagnosis and we have to tell what is the next appropriate test. A person is brought to the hospital for evaluation of drooping of eyelids and muscle weakness and fatigue more towards evening. She also had dysphagia. Evaluation showed normal blood parameters. CT check showed the following finding. So in 2024, many NEET questions were like integrated questions. Like it was not a straightforward image question. So questions were mixed from medicine and radiology, medicine and ophthalmology findings like that. So that's why this is such a big question. So I will decode the question. Patient has drooping of eyelid, which is ptosis. Patient had muscle weakness and fatigue. The clue here is it is more towards evening. So I think most of us would have come to a diagnosis. This is a clear case of myasthenia. So myasthenia actually presents with muscle weakness. Muscle weakness all over the body. So they may have limb weakness. They may have ptosis, drooping of eyelid. So it is eyelid weakness. They may have dysphagia. So it could be any weakness. Sometimes patients will not be able to tell the diagnosis of weakness and they just report fatigue. So the clue can also be fatigue. But the word is fluctuating fatigable weakness. So clearly this is myasthenia gravis. Why there is actually a fluctuating weakness? Because as time goes on, as more activity is done, you know very well that myasthenia gravis is a problem with anticholinesterase or acetylcholinesterase antibody. Maybe we can explain with a simple neuromuscular junction. So this is the nerve ending and assume that this is the muscle. So this is the neuromuscular junction. So normally muscle endings will release acetylcholine. I think we can enlarge the image. Nerve endings will release acetylcholine receptors, acetylcholine. Those acetylcholine will bind to acetylcholine receptors in the muscle end plate. That leads to action potential and muscle contraction. This is how things occur. So in myasthenia gravis, what happens is there are antibodies which are produced against these acetylcholine receptors. So acetylcholine receptors in short are labeled as AChR. So we have anti-acetylcholine receptor antibodies in myasthenia gravis. So what happens when antibody attacks these? The number of receptors reduce. So the binding of acetylcholine to the acetylcholine receptors in the muscle end plate reduces. So action potential reduces, muscle contraction reduces. As time goes on, the fatigue will increase or weakness will increase because some amount of all the receptors get utilized as action goes on. Okay, assume there are 100 receptors initially and 100 functioning receptors initially, and there is 50 acetylcholine released. But as time goes on, more number of acetylcholine vesicles get released. So all the receptors get utilized. Already the number of receptors are low in myasthenia gravis. So that is why. Because of the number of acetylcholine receptors get utilized by acetylcholine with prolonged activity, there will be worsening weakness. So this is called as decremental response. That is, when we are doing electrophysiological study, when we are continuously giving electrical stimulation in myasthenia gravis, the action potential decreases. That is called as decremental response. There is one disease which is opposite of this, that is causing an incremental response. This disease also causes muscle weakness. So decremental response is reduced action potential with continued muscle activity. It is due to increased acetylcholine receptor engagement occurs in myasthenia gravis. Incremental response is increased action potential with further muscle stimulation. This occurs in a disease called Lambert-Eaton myasthenic syndrome. So these two will be the differential diagnosis. Myasthenia gravis is a primary disease usually associated with thymoma. Lambert-Eaton myasthenia syndrome is a paraneoplastic syndrome associated with small cell carcinoma of lung. This myasthenia gravis is a problem with the post-synaptic acetylcholine receptors, right? Whereas this Lambert-Eaton myasthenia syndrome is a problem with this presynaptic calcium channel. You know very well that there are some calcium channels in the nerve ending. When calcium enters, they help in release of acetylcholine vesicles into the neuromuscular junction. So this Lambert-Eaton myasthenic syndrome is a problem with presynaptic calcium channels. Remember, these presynaptic calcium channels are also the ones which are affected in crate bite, whereas the postsynaptic is affected in cobra bite. Okay. So here the receptor is anti-acetylcholine receptor antibody. Here it is voltage gated calcium channels, VGCC channels, presynaptic VGCC channels, or the antibodies, anti-VGCC. Okay. So, and decremental response, incremental response. How will you treat myasthenia gravis? We have to increase cholinesterase. So acetylcholine receptors are getting broken. So we have to increase as much acetylcholine as possible. So we have to give cholinesterase inhibitors. Cholinesterases are enzymes which break down acetylcholine. So when we inhibit cholinesterase, acetylcholine levels increase, so they can bind with more receptors. Right? So cholinesterase inhibitor, example is pyridostigmine. If you remember, OPC poisoning is also cholinesterase inhibition, right? We have neostigmine. Plus we can use steroids here. Now what about Lambert-Eaton myasthenic syndrome? It's a paraneoplastic syndrome. So we have to remove the antibodies. The treatment here is plasmapheresis. Okay, so just a small revision about Lambert-Eaton myasthenia syndrome versus myasthenia gravis. So this question is clear. They are given a decremental response. So more towards evening, fatigue and muscle weakness increases. There is ptosis and dysphagia. So this is clearly myasthenia gravis. And see the clue, this is thymoma, right? Anterior mediastinum, there is a mass, so this is a thymoma. So this is clearly myasthenia gravis. The question is simple. Which is the next step to order? Anti-acetylcholine receptor antibody, anti-MuSK. Seems right. Creatine kinase levels are increased in muscle disorders. This is a neuromuscular junction disorder. So this is not the answer. Calcium levels have nothing to do here. Vitamin D levels also have nothing to do here. So the answer is more or less straightforward. But since the question is long, we should be careful in identifying it. So coming to question 24 of previous year NEET PG 2024. So this is also image based big question. The question is, what's the gold standard test? So the scenario is a 55 years female presents with abnormal movements of upper limb for the past 3 months. She gives history of jaundice and history of taking native medicines for the same for the past 1 year. Her eye examination showed case of Fleischer ring and icterus. And I think the image is quite clear. There is a brown ring around the cornea. So this is Kaiser Fleischer ring. There are some abnormal movements. Plus there is jaundice. So clearly this is Wilson's disease, because Wilson's disease is also called as hepatolenticular degeneration. We know very well Wilson's disease is an autosomal recessive disease associated with a problem with copper transport in the body. So excess copper gets deposited in tissues. So it is actually a problem with copper transport. Ceruloplasmin is the copper storage protein in the body. Ceruloplasmin. So ceruloplasmin gets reduced. So usual level is less than 25 milligrams per deciliter. As a result of copper transport protein, when it becomes low, when ceruloplasmin becomes low, copper gets excreted in urine. So urinary 24-hour copper becomes increased. But the hallmark is the excess copper in the blood gets deposited in many organs, especially the liver and the lens. Lens is actually basal ganglia of the brain. So when it deposits in the liver, it causes jaundice or liver failure. Remember, Wilson's disease is one cause of, other than alcohol and other than fatty liver disease, Wilson's disease is one cause of cirrhosis. And when it deposits in basal ganglia of brain, it causes abnormal movements. Usually they say the typical movement disorder is wing beating tremors. It's a coarse tremor of the upper limbs. Of course, any movement disorder, any dystonia can occur with Wilson's disease, but the classical one is wing beating tremor. Since image based questions are common, wing beating tremor may be kept, the same scenario may be asked, and we may be asked to diagnose Wilson's disease. This question, though it is big, the answer is straightforward. It's a case of Wilson's disease. The question is, what's the gold standard test for Wilson's? I already told you serum ceruloplasmin levels becomes low in Wilson's disease, less than 25 milligrams per deciliter. We can say that it is an investigation of choice. 24-hour urine copper excretion. Usually these two are done together. Urine copper, 24-hour copper excretion becomes increased. This is also the investigation of choice. These two are usually done together. But the question is gold standard. To prove Wilson's disease, there should actually be liver biopsy for copper level estimation. The dry weight of the liver to measure for copper should be done. This is actually the gold standard. So this is a theoretical question. Usually it is not done. It is diagnosed from other things. MRI brain shows a feature which is giant panda appearance. As I already told you, the copper gets deposited in the basal ganglia. That looks like a giant panda. I'll show you the images. One thing to note from this history is, remember, the patient initially had jaundice initially, then only she developed movement disorder. So neurological findings do not come first in Wilson's disease. Jaundice or cirrhosis comes first and neurological findings comes last. The final treatment here is liver transplant. There are some drugs like D-penicillamine, zinc, triamterene. So these are some drugs which are used in Wilson's disease. But once cirrhosis sets in, we need liver transplant. But once brain changes occur, liver transplant is contraindicated, means there is no use in doing liver transplant. So the gold standard for Wilson's, liver copper estimation, investigation of choice, serum ceruloplasmin and 24-hour urine excretion. We have to remember two storage diseases. This is Wilson's. This is a disease called NBIA, brain iron accumulation. Neurodegeneration with brain iron accumulation. It's called Haller-Walden's disease. Don't think of the details. This is the region of basal ganglia actually. You can see multiple deposits here. See, it looks like the panda's face, giant panda face. Okay, if you are able to appreciate. Whereas see this one, you can see some deposits here inside. So this looks like a tiger eye, right? Okay, so just thinking from your mind. Wilson's causes giant panda face appearance, and Haller-Walden's disease causes tiger eye appearance. Few other MRI is also important in neurology or in radiology from NEET point of view, like that of Parkinson's disease, okay, and Parkinson plus syndromes. If questions comes, I'll show you those images also. So coming to question 25 of previous year NEET PG. So this is also a very big question. What will be the ideal treatment regimen to plan? So try to find out the diagnosis as we read the question. 18 years old male has recurrent fever and petechial rashes all over the lower extremities. Clinical examination shows splenomegaly. Few lymph nodes are palpable in the neck. The clinician admits the patient and orders lab tests. The complete blood count comes as follows. HB was 7 gram per cent, total count was 50,000. Differential count showed a predominance of lymphocyte, platelets are 55,000. So you can note down the clues. So what's the history is patient is having fever plus petechial rashes. Petechial rashes means it's a hallmark of thrombocytopenia. So we can take petechia. There is splenomegaly. Spleen enlarges due to various conditions. Here there is splenomegaly. And few lymph nodes are palpable. So it's a lymphadenopathy. No other clue is given clinically. Now what is the lab shows? HB 7 gram per cent. So it is actually severe anemia. Counts are increased with predominance of lymphocytes. So it is leukocytosis, lymphocytic leukocytosis. And platelets are low, so thrombocytopenia. So after reading so much of pathology, maybe after seeing this question, one thing may look clear. This looks like some sort of hematological malignancy, right? This is some hematological malignancy. So whenever hematological malignancy comes in our mind, we always have to think of either a leukemia or a lymphoma. Lymphoma will not present with that much of blood manifestations or blood count changes, but they present with only generalized lymphadenopathy. So you know very well there is Hodgkin's lymphoma, non-Hodgkin's lymphoma. You would have discussed in your pathology. Now leukemia is of 4 major types. AML, acute myeloid leukemia, chronic myeloid leukemia, acute lymphoblastic leukemia, chronic lymphoblastic leukemia, right? Sometimes lymphoblastic leukemia and lymphomas may come together. See, it's a young age male. Only one hematological malignancy is common in young age, that is ALL, right? Second, from the clue, there is lymphadenopathy and splenomegaly. So lymphadenopathy is there. So either it is a lymphoma or a ALL or a CLL. So again ALL can be marked. Remember a simple tip in to differentiate simple tip to differentiate AML or ALL from CML or CLL. In acute leukemias, usually counts will be low. Means usually there will be anemia or thrombocytopenia. Sometimes even total count will be low. Despite being a leukemia, even total count can be low in acute myeloid leukemia or acute lymphoblastic leukemia. Or even if the count is high, anemia or thrombocytopenia will be there. But in CML or CLL, everything will be high. That is a simple clinical clue. May not hold true always, but may be worthwhile remembering. So in this case, see, HB is low, platelet is low, only total count is high, that too with a lymphocytic predominance. So again, ALL comes there. Since other anemia thrombocytopenia is there, CLL is not the possibility. So pediatric age, predominance of lymphocytes, presence of lymphadenopathy, and if you want to go in depth, fever with joint pain will be the usual presenting manifestation in ALL. So all this points towards ALL. So what's the treatment for ALL? So even if these options confuse you, please remember any disease in our body with lymph node, right? Be it a lymphoma or be it ALL or CLL, always steroids have a role. Steroids will have a response. So most of the regimens like ABVD regimen, or many lymphoma regimens will have steroids. Okay, even if you don't remember the regimen, it's not an issue. But if you are able to pick up this prednisolone, this is the answer. Okay, what about lymph node radiotherapy? Patient has only few lymph nodes over the neck. Plus, patient is having blood changes than lymph node changes. So this is not a lymphoma, this is a leukemia. So this may not be an ideal option. So this holds good. IVIG is a treatment of choice for other diseases like Guillain-Barré syndrome, not here. Doxorubicin, we don't know much about that, so leave off this option. Don't get confused with options which you don't know, right? So this is ALL. Coming to question 26 of previous NEET PG, another hematology question. So question is about what's the diagnosis. So 43 years old female comes with anemia, 5.8 gram per cent. She has history of fibroid uterus with abnormal uterine bleeding. Further evaluation showed peripheral smear showed pencil cells, microcytic hypochromic picture, serum iron was 10, ferritin was 1, TIBC was 500. So don't get confused. Whenever in such big questions, focus on the last word, what's the diagnosis, and try to note down the clues. So it's a case of anemia, severe anemia in a female who has abnormal uterine bleeding, right? This itself will solve most of the things, right? Every word is important in a question. And from the reports, peripheral smear showed pencil cells. Remember, pencil cells is very, very typical of iron deficiency. Like you would have read, target cells are very specific for thalassemia. Bite cells, which occur in G6PD deficiency, or other diseases like thrombotic microangiopathies like HUS or TTP. Likewise, pencil cells occur in iron deficiency. So that is one straightforward clue. Usually they will be giving the reference ranges here, but if you remember, iron will be normally more than 20 microgram per deciliter. 10 is low. Ferritin is only 1 nanogram per deciliter, which is very, very low. It has to be at least 10 nanograms per deciliter. So iron is low, ferritin is low. TIBC, if they are given the reference range, the normal reference range is up to 400 micrograms per deciliter. Here it is 500, so TIBC is increased. TIBC is nothing but the free transferrin. Okay, transferrin is a protein which transports iron. When iron is low, transferrin will be high automatically because there is not much of free transferrin which is not bound to iron. So low iron, high TIBC, low ferritin. There is another ratio called iron by iron binding capacity. That ratio is called as transferrin saturation. That is also low in iron deficiency. Okay, so even if you are not very well versed with this thing, please remember the clinical clue. There is a bleeding. There is an abnormal bleeding, right? So most probably iron is getting lost. So this usually will be iron deficiency anemia. Suppose they are giving you a clinical clue where there is no abnormal uterine bleeding. It's a young female without any comorbids, presents with such microcytic hypochromic anemia. You can think of other things. So a small discussion about microcytic hypochromic anemia. Again, this is a pathology plus medicine integrated question. There are 4 causes of microcytic hypochromic anemia. Remember with the mnemonic SITA. S for sideroblastic anemia. I for iron deficiency anemia. T is thalassemia. Anemia of chronic disease. Always in big questions, try to pick up even small clinical clues. Like sideroblastic anemia, sidero is iron. There will be always things of iron excess. Like ferritin will be high, iron will be high. And plus, one clinical manifestation of iron overload is there will be discoloration of skin. Right, the so-called bronze discoloration of skin. Iron deficiency anemia, just now we had discussed. Patient presents with some bleeding manifestation, reduced iron intake, and iron deficiency in children will cause reduced concentration. There will be abnormal food habits, pica. Okay. Worm infestation history may be given. Thalassemia is a hemolytic disorder, so it's also an autosomal recessive disorder, so there may be a family history. Consanguinity history may be given. Okay. And there will be no comorbids like bleeding, and it will be younger age of onset. Please remember, thalassemia major is a hemolytic disorder. Thalassemia trait is the actual differential for microcytic hypochromic anemia. Okay, thalassemia major is a hemolytic disease. It presents with differently like hemolytic phases, etc. Anemia of chronic disease, they'll have some chronic disease like anemia of CKD. Now, what will be the hallmark in chronic disease? Ferritin being an inflammatory marker, ferritin will be high. Transferrin will be low. That is TIBC is low. Like it's the opposite of iron deficiency, right? So an iron deficiency anemia versus anemia of chronic disease. Iron is low. Ferritin is low. TIBC is high. Here it's the opposite. In anemia of chronic disease, iron is normal to high. Ferritin is actually high. Ferritin is an inflammatory marker. TIBC, transferrin is a negative inflammatory marker. It gets reduced. So TIBC will be low. So this is how you analyze this case. So this is clear. Patient is having anemia with a bleeding disorder. There is pencil cells, microcytic hypochromic anemia, so one among SITA. Iron is low, TIBC is high, ferritin is low. So this is iron deficiency anemia. This is not anemia of chronic disease because no chronic disease is given. It's not sideroblastic anemia because ferritin is low. Thalassemia major is a totally different entity. It's a hemolytic anemia. Had the option been thalassemia trait, we could have thought about it, but thalassemia trait usually never produces severe anemia. It only produces mild anemia. So this is also not the option. So coming to question 27 of previous year NEET PG. So very short, small question. Which are the following is not true? Remember, it's not true. We have to find the false statement. So it's about von Willebrand disease. Okay, like it's a theoretical question only. Von Willebrand 1 is the most severe form in children. Actually, it's the wrong statement. So we have 3 types of von Willebrand disease: 1, 2, and 3. So what is von Willebrand factor? It is a factor produced by the liver. It helps in binding platelets with the damaged endothelium. So this binding helps to activate the platelet aggregation. So you know very well, hemostasis starts with vasoconstriction, platelet aggregation, next is platelet agglutination. So after vasoconstriction, when the damaged endothelium of the blood vessel comes in contact with von Willebrand factor, the von Willebrand factor binds to endothelium in one side and it binds to platelets on the other side, and it activates the platelets, leading to platelet aggregation. That is the normal physiology. So a deficiency of von Willebrand factor is called von Willebrand disease. We have 3 types. 1 is the most common. Okay. 3 is the most severe. One is actually mild deficiency of von Willebrand factor. 3 is severe deficiency of factor, but it is less common. So most common is von Willebrand factor, least severe is von Willebrand factor disease type 1. The severe one is von Willebrand disease type 3. What about type 2? Type 2 is not a quantitative defect, it is a qualitative defect in von Willebrand factor. At least remember this one. So it causes mild to moderate bleeding. Severe bleeding is with von Willebrand disease 3. The 3 are having different types of inheritance. One is autosomal dominant, one is X-linked, another one is autosomal recessive. I am not telling that here. So von Willebrand disease 1 is the most severe form in children. False. It is the most common form. So the answer is which of the following is false. So this may be the answer. Anyway, read the other options. Von Willebrand disease 2 is a functional defect in von Willebrand factor rather than a quantitative defect. This is the true statement. Von Willebrand disease 3 is the most severe form in children. That is also true. Von Willebrand disease 3 has severely low levels of von Willebrand factor. That's also true. So obviously option A has to be the answer. So in such a question, if you are stuck up and if you have time, don't leave off this question, because if you read the options carefully, you can very well see the options are contrasting with each other. They are given von Willebrand disease 1 is the most severe form in children. Option C reads von Willebrand disease 3 is the most severe form in children. So these two are contrasting options, which means one of them has to be correct, one of them has to be wrong. See option D. Von Willebrand disease 3 has severely low levels of von Willebrand factor. Option 3 and option 4 go together, right? Since von Willebrand disease 3 has severely low levels of von Willebrand factor, obviously that is the most severe form. So 3 and 4 go together. So these two have more chances of being right. So option 1 is being left out. So that is the answer actually. So you should also have some thinking skills beyond your knowledge in your NEET exam. So don't get tensed in the exam. Even if the question is long, read the last line. Try to pick up every clinical clue and try to come to the answer. Some clue will lead you to the answer. Even if you are not sure of anything, read the options and try to analyze the options. Somewhere you can get the answer, right?